Sure.
Welcome once again to this edition of the webinar series, the University Webinar Series, and this being the first for the year 2022. Happy New Year to all who have joined. And for those of you who may not be very familiar, this university had been conducting a webinar series. Thanks to COVID, we thought we'll go online and have educative sessions. And today we have Dr. Narayanan, who's our honorary adjunct professor and an endocrinologist, talking to us on the endocrine emergencies. And in the panel, we have Dr. Jaishri Gopal and Dr. Muthukumaran Jaipal. Dr. Narayanan is currently the consultant endocrinologist at the Apollo Hospitals, Chennai, and he has a long experience in endocrinology, especially with years spent at Cambridge University Hospital in the UK. And he has several publications to his credit, especially in subjects related to endocrinology, diabetes, and metabolic disorders. And he has participated in several international presentations and has also bagged prizes for his presentations and publications. I have great privilege in welcoming Dr. Narayanan and would not want to stand between Dr. Narayanan and the listeners. And I also take this opportunity to welcome Dr. Jaishri Gopal and Dr. Muthukumaran Jaipal. Dr. Narayanan, the floor is yours, and the panelists probably could intervene once Dr. Narayanan completes his main presentation.
Thank you very much.
Now.
Thank you very much, ma'am, for your kind introduction. It's a great honor for me that I've been introduced by one of my most respected teachers. You may not remember, you were my anatomy professor when I joined my first year medical college at Stanley. So thank you very much for.
Thank you. It's nice to see students across the globe and doing very well. That's the pleasure of being a teacher. Thank you very much.
Good afternoon, all the delegates. And it's my honor to introduce the co-panelists, Dr. Jaishri Gopal and Dr. Muthukumaran Jaipal, who very kindly immediately accepted to be the panelist today. Dr. Jaishri Gopal is the director of DiabEndo India, Institute of Diabetes, Endocrine and Metabolic Health. She holds a diploma in American board, both in internal medicine and endocrinology. She is a senior consultant endocrinologist at Apollo and also an associate dean for teaching and research at MV Diabetes Research Center, Rayapeta. She has got several awards, the most prominent of which is the SAMGP Oration, which she had at the API Chennai chapter. Our next panelist is Dr. Muthukumaran Jaipal, a very nice colleague of mine. He's a consultant endocrinologist and managing director of ARCA Center for Hormonal Health. He finished his training in the UK, his postgraduate training in the UK. He holds a research degree of MD from the University of Newcastle upon Tyne. And he's a honorary secretary for Endocrine Society of Tamil Nadu and Pituitary. And he has held the post of honorary treasurer in the past. So thank you, both of you, for kindly agreeing to be part of this CME today. So shall I start off with the CME? Are the slides visible?
Yes, sir. Yes.
Am I audible?
Yes, you are audible. Slides are also visible, sir. You can start.
Okay. Many thanks to the M.G.R. Medical University, our VC, for giving me this opportunity. I'm going to be talking for the next 45 minutes on endocrine emergencies. Rather than a didactic lecture, what I thought would be, it would be interesting to have a case-based discussion. What I would do is highlight some of the endocrine emergencies that we come across. Endocrinology as such is predominantly an outpatient-based specialty. About 80–90% of our work is in the outpatients, but we do come across interesting inpatient endocrine situations on emergencies, which people may not be aware of. So I've got a series of cases lined up. As I said, for the next 40 minutes, we'll walk through these cases and go through the learning points through these cases. I'll start with the most simple case and then build up gradually to the more complex cases later on during the presentation. So as I said, there are various endocrine emergencies that we come across. The most common, everyone is aware of, are emergencies with regards to diabetes, that is hyperglycemia, diabetic ketoacidosis, and hyperosmolar non-ketotic coma. Hypoglycemia, severe hypoglycemia requiring third-party intervention and hospital admission. So I'm not going to touch upon these because we would have heard multiple times about these emergencies. The other endocrine emergencies are electrolyte homeostasis disturbances like hypercalcemia or hypocalcemia, the organ-related dysfunctions, which can present like an emergency, for example, thyroid storm, acute thyroid ophthalmopathy, myxedema coma. Fortunately, we don't see that so often nowadays because of the frequent testing that we come across. Acute presentation of Cushing's, acute hypoadrenalism, and hypertensive crisis like pheochromocytoma crisis, or acute presentation of hypopituitarism with either cranial nerve palsies or pituitary apoplexy, that is hemorrhage into the pituitary gland. So let me start off with my first patient today, 59-year-old female. She was found unresponsive in the bed by her relatives. Now, these are real life patients whom I have personally managed. So this patient was found unresponsive in the bed, but by the time the ambulance crew went home, tried to wake her up, she was becoming slightly more responsive. The history is that over the preceding 6 months time duration, she had been having profound tiredness and lethargy, constipation, cold intolerance, and decreasing physical and cognitive activity. On examination, the responses were slow, the mentation was slow, the reply was slow. She was hypothermic with a temperature of 95 degrees Fahrenheit. Pulse was about 48 to 50 bradycardic. There was no palpable goiter. The blood pressure showed a lying, standing drop in blood pressure. Now, this is a textbook description of someone who has probably got hypothyroidism with the tiredness, lethargy, constipation, cold intolerance, decreasing cognitive, bradycardia, hypothermia. It's a textbook description of hypothyroidism. So the clinical impression was hypothyroidism indeed, but the TSH came back as being very normal at 1.4. Now, often we notice that in the general physician practice that as a screening tool for thyroid, TSH is the most common test that is used, which is very appropriate that we use TSH as a screening tool. But situations like this, where the clinical impression is that this lady has got hypothyroidism, but the TSH is completely being normal at 1.4, makes us think either the report is wrong or we are missing something here. Look at the next report here. We went ahead and did the free T4. That came back as being profoundly low. Now, the T4 reports will be consistent with the clinical presentation of hypothyroidism. So normally we know that the pituitary axis works in a negative feedback mechanism. So the end organs, let's say, for example, the thyroid axis, if the T4, T3 is decreasing, the pituitary responds by increasing the TSH levels. So you would expect a low T4 and a high TSH in a typical presentation of hypothyroidism, which is typically called the primary hypothyroidism, which is the most common form of hypothyroidism. But we should not miss secondary hypothyroidism or hypopituitarism. When a clinical presentation is like this, but the TSH is normal, then definitely we should go ahead and do further testing to prove or disprove our clinical suspicion. The other pituitary hormone axis showed that the other pituitary hormones were also low. The LH, FSH, prolactin, the synactin test, which tested the cortisol, the IGF-1, which is the marker of growth hormone, all being on the low side, confirming the suspicion of hypopituitarism. And this hypopituitarism was related to the pituitary tumor which she had. This is the first image is the coronal section of the brain, which shows a large tumor, which I am pointing out here with the laser pointer, a large pituitary tumor with a central black area, which was the hemorrhage into the pituitary tumor. So this is a sagittal section of the same thing. Again, a large pituitary tumor with hemorrhage into the pituitary gland, confirming that this lady indeed had a pituitary adenoma with apoplexy causing anterior hypopituitarism. So when we have a situation like this, where there is a coexistent hypothyroidism and cortisol deficiency, obviously the first thing we ought to treat would be the cortisol deficiency, because if we start them on thyroxine as the first agent of treatment, then the thyroxine will drive the metabolism and the body will not be able to cope with that when there is coexistent cortisol deficiency. Now, the second patient who I've got here is a 49-year-old male. This is not actually an endocrine emergency, but when we looked at the first patient, this second patient would sit in very nicely as a complementary presentation to the first patient. As a learning point, this would be very helpful, and hence I've included this patient here. The presenting complaint was palpitations. He gave a 2-year history of sleep disturbance, anxiety, heat intolerance, palpitations, tremor, excessive sweating, weight loss with increased appetite, and loose stools. His past medical history included a diagnosis of dilated cardiomyopathy. This was attributed to alcohol, although he said he was not drinking much alcohol at all. In the past, he has also had episodes of non-sustained ventricular tachycardia. He had a label of depression and paranoid disorder. Those were the medications that he was on at the time of presentation. Again, opposite to what our first patient had, the second patient has got a textbook description of hyperthyroidism. On examination, he had a fine resting tremor, small smooth goiter. He was tachycardic at 110 on beta blocker. Blood pressure was normal, JVP was normal, chest was clear. There was no thyroid eye disease or pretibial myxedema. So the clinical suspicion is thyrotoxicosis due to what? As in our first patient, when the TSH was done, this turned out to be completely being normal at 2.9. Like our first patient, where there was a strong suspicion of hypothyroidism, here there is a strong suspicion of hyperthyroidism, but the TSH is normal. So we went ahead to do the T4 and T3, both of which came back as being elevated, which were consistent with the clinical presentation. Like with our first patient, here again, when the T4 levels are high, because of the negative feedback, you would expect the TSH to be suppressed. It would be normally less than 0.01 in patients who have got, for example, a Graves' disease causing thyrotoxicosis. When the T4 is elevated, if the TSH is not suppressed, there are quite a few differential diagnoses which we have to go through, one of which, given his presentation of thyrotoxicosis, one of which is what we call as a TSH secreting pituitary adenoma. This is the sagittal section of the MRI of this gentleman, which showed a large pituitary tumor, and we can see dark black spots within the tumor itself. On an MRI, the dark black spots could represent either blood or calcium. So to confirm whether this was an apoplexy or not, this is a CT scan, which is an axial section. This is a cella here, and we can see this is the enlarged cella of the pituitary tumor. And these white deposits, what we are seeing on a CT scan, confirms that these are indeed calcium deposits into a pituitary tumor. Now, calcification of pituitary tumors occur, as far as I know, in only 2 conditions. One is the TSH secreting pituitary adenoma, like what this gentleman has got, or another rare condition called pituitary stone. So the treatment for this condition would be to block the thyroid hormones with maybe a somatostatin analog therapy, and then to take him up for surgery to remove the pituitary tumors. So these complementary cases tell us that when there is a strong suspicion of hypopituitarism, we should not stop with just measuring the TSH. The learning points, the key points from these cases are that hypopituitarism, due to whatever reason, whether it's an adenoma or some other reason like apoplexy, often develops and presents in an insidious manner, in a very gradual manner. Therefore, the symptoms are not very typical all the time to label immediately that as hypopituitarism. Hence, hypopituitarism is often called the master of disguise, which means we can be deceived by the presentation and we can easily miss the presentation. Like in these patients who had an insidious onset of lethargy and tiredness, often it can be put down to other common reasons like age-related, anemia-related, vitamin deficiency, etc. So measurement of TSH alone is insufficient to exclude when there is a suspicion of central thyroid dysfunction, or what we call as a secondary hypothyroidism. If central endocrine disease is suspected, then we have to check paired hormones, which means the pituitary hormone as well the end organ. So for example, TSH and free T4, or ACTH and cortisol. The third patient is a 56-year-old female who presented with breathlessness and palpitations. She gave a 5-day history of worsening breathlessness, reduced exercise tolerance, and increasing frequency of what she described as fast palpitations, and she was getting more and more agitated. There was nothing of significance in her past medical history. She was not on any medications. There was nothing else otherwise of note in the past. On examination, her GCS was 15. She was quite agitated in the emergency room, had some paranoid ideas. Temperature was elevated at 101.3. She had warm peripheries, and there was a moderately diffuse goiter. Clinically, pulse was 140 per minute, and clinically it seemed like atrial fibrillation with an irregular pulse. The lying and standing blood pressure also showed a postural drop. Jugular venous pressure was elevated. There was bilateral ankle edema, and she had bibasal crepitations, otherwise nil of note from the central nervous system. So the clinical suspicion is whether this lady has got a fast atrial fibrillation, congestive cardiac failure due to chest sepsis, or whether there is an underlying infection which has precipitated what could be consistent with a thyrotoxicosis presentation. Because she has presented to us with all the features of thyrotoxicosis, with an elevated temperatures, warm periphery, diffuse goiter, so she could have a thyrotoxicosis as well. That's her ECG, which confirms the clinical suspicion of atrial fibrillation, and the chest X-ray showed an enlarged cardiac silhouette with obliteration of the cardiophrenic angles, the costophrenic angles, confirming that this lady has got cardiac failure. The clinical suspicion is confirmed by the thyroid profile with a suppressed TSH, elevated T4, and elevated T3. So in contrast to our second patient, where the TSH was still detectable when the T4 was elevated, here with an elevated T4 and T3, the TSH is fully suppressed, which means this gentleman has got a primary hyperthyroidism, could be due to Graves' disease. Now, the only difference is this is not the box standard thyrotoxic patient that we see in our clinic day in and day out, who walks in to say that they have got palpitations and excessive sweating. This lady has presented to the emergency with both cardiovascular and neurological symptoms, i.e. paranoid ideas, agitation, signs of cardiac failure, postural drop in blood pressure, being hyperthermic. So this is not a very straightforward thyrotoxicosis. This is one of the important endocrine emergencies that we should not miss, because the mortality rate is about 25%. So this lady has presented with what we call as thyrotoxic crisis or thyroid storm, where treatment is at most important to be instituted immediately, lest the mortality is high. It's a rare but potentially fatal disorder, typically arising in the setting of unrecognized thyrotoxicosis or severe or poorly controlled thyrotoxicosis, especially with Graves' disease. There could be certain precipitating factors like intercurrent illness or trauma, surgery, childbirth, or any other acute complications in the pulmonary or cardiovascular. For example, a lung infection or an acute MI. All these could precipitate or tilt the balance towards a thyrotoxic crisis or thyroid storm. The presentation is hyperpyroxia, profuse sweating. There are signs of restlessness and agitation like what our patient has got. They can present with frank psychosis, tachyarrhythmias, and congestive cardiac failure. The cardiovascular and the neurological symptoms dominate the picture of a thyrotoxic crisis. So it's important that we pick this up and not treat this simple as a simple thyrotoxicosis. Now, how do we treat this? Just we need to recap the thyroid hormone action. The hypothalamic TRH, the thyrotrophin releasing hormone, secretes the TRH and stimulates the pituitary to produce TSH. TSH acts upon the thyroid gland to produce T3 and T4. We should remember that all the pituitary hormones except prolactin, are under tonic stimulation from the hypothalamus. Prolactin is the only hormone that is under tonic inhibition. Now, this T3, T4 executes its action at the cellular level, where it promotes iodide intake into the cell, and it promotes via the thyroid peroxidase enzyme. The T3, T4 is synthesized within the follicular cell, where through the iodine trapping, the T3, T4 are synthesized and secreted out of the cell. Once the T3, T4 is secreted out, it circulates in the blood circulation, where more than 99% of it is bound to the proteins like the TBG, thyroid binding globulin, albumin, or prealbumin. So the free hormone is very minuscule, less than 0.5% in the circulation in total. This T3 and T4, the free hormones especially, executes its action at the peripheral level, the brain, heart, liver, and the muscles. At the cellular level, the T4 gets transported into the cell, gets converted to T3 using the deiodinase enzyme, and the T3 receptor is an intranuclear receptor, where it executes both genomic and non-genomic actions. So if we recap this, to treat thyrotoxic crisis, there are several steps which we can attack or address as a treatment. The first treatment that we should institute would be an anti-thyroid medication, typically a carbimazole or propylthiouracil. Amongst this, propylthiouracil has got slightly more advantage compared to the carbimazole because it's quick in action, and it also inhibits the peripheral T4 to T3 conversion. If we recap, amongst the T4 and T3, T3 is the one which is most biologically active and is responsible for all its actions in the periphery. Therefore, you want to block the conversion of T4 to T3 immediately, where PTU would be more helpful. The carbimazole and PTU act on the thyroid peroxidase enzyme here and block the action. Therefore, the thyroid hormone synthesis is inhibited. It's not the secretion, it's the synthesis that is inhibited. The second agent, which we rarely ever use in other settings of thyrotoxicosis, is iodide. We all know that iodide is a substrate for the thyroid hormone production, both the T3 and the T4. So it seems paradoxical that we use iodide to treat thyrotoxicosis, but it goes by this theory that it's called the Wolff-Chaikoff effect, where administration of a large quantity of iodide will inhibit the thyroid peroxidase enzyme. This is a auto-regulatory mechanism which the follicular cells in the thyroid have got, where when there is too much of iodide that is available, the TPO gets down-regulated and blocked. Therefore, the thyroid hormone synthesis is also blocked. Now, it's very, very important that we don't administer this as the first agent, because without blocking the TPO enzyme, if you just give iodide, the thyrotoxic crisis can get worse. Therefore, the first drug should be an anti-thyroid medication, then you administer the iodide. The other agents that we use are more of a symptomatic management, propranolol or esmolol, depending on the requirement. This will inhibit the action of the T3 and T4 in the peripheral tissues. For example, the autonomic hyperactivity that we see in these people with tachycardia, tachyarrhythmia can be ameliorated with the use of beta blockers. Glucocorticoid therapy, either in the form of dexamethasone or hydrocortisone. The role of steroids in this situation is that it also inhibits the conversion of T4 to T3 and thereby will inhibit the action of the already circulating T3. Other measures like oxygen, IV fluids, paracetamol, active cooling. And one important thing to mention is we should avoid giving aspirin in this sort of situation where there is a thyrotoxic crisis. The reason is aspirin will displace the T3 and T4 from the binding proteins like the prealbumin or the thyroid binding globulin. Therefore, the free hormone levels will increase, and hence the thyrotoxic crisis can get worse. The other treatment like digoxin, diuretics, chlorpromazine, antibiotics if there is an evidence of infection, and of course, correcting and treating the underlying precipitating cause are very important in the management of thyrotoxic crisis. So the key point from the third case, uncontrolled thyrotoxicosis is a potentially life-threatening disorder. As I said, the mortality goes up to 25%. Consider the diagnosis if there is evidence of cardiac or neurological dysfunction in conjunction with thyrotoxicosis. Early and aggressive treatment is required to switch off further thyroid hormone protection and inhibit the T4 to T3 conversion and block the features of adrenergic excess. The fourth patient is a 73-year-old female. She presented with dizziness, nausea, and vomiting. She gave a 6-week history of progressive dizziness on standing associated with increasing lethargy 7-day history of reduced appetite with nausea and vomiting. She had a history of breast carcinoma in 1991, which was treated with surgery and radiotherapy. Subsequently, in 2002, she was found to have skeletal metastases, for which she had chemotherapy and hormonal therapy. At the time of presentation, she was only on tamoxifen. She was aparaxial, she was looking pale, she had a dry skin with reduced body hair, and the blood pressure was lowish at 90 by 60 lying and 70 by 40 while sitting, but there was no tachycardia. Normally, you would expect a response from the cardiac side when there is a hypotension, but the pulse was 80 per minute and the JVP was decreased or low. Other system examinations were unremarkable. Now, these are her initial presenting biochemistry. The couple of things which I want to highlight here, we need to bear this in mind as we walk through this case. The creatinine was elevated, but the urea was low. It's very common for us to see the other way around, where there is a disproportionate increase in urea with the normal creatinine. Example, in cases with dehydration or gastrointestinal bleed, where this is opposite, where the urea is low, but the creatinine is elevated. The clinical suspicion here was whether this lady has got hypoadrenalism, because she has got a previous history of cancer and now presenting with dizziness, postural drop in blood pressure, hypoglycemia with the blood sugar of 63. So hypoglycemia, hypotension, in this context, this presentation could be fitting in with hypoadrenalism. Now, with box standard hypoadrenalism, we would expect a hyponatremia and a hyperkalemia. So this is the second important and interesting abnormality which I would like to point out here, where this lady has got a very normal sodium and, if at all, a lowish potassium. So she does not have the classical metabolic feature of a hyponatremia and a hyperkalemia, which we see most often in patients with hypoadrenalism. Nevertheless, the clinical suspicion is still whether this patient has got hypoadrenalism. The TSH was normal at 1.1. The short synaptin test confirmed that this lady does not have enough cortisol in her body. So the admitting team, she was initially admitted under general physician. The admitting team appropriately gave her 25% dextrose to correct the hypoglycemia and started her on IV fluids to correct the hypotension. When the short synaptin test results were available confirming the clinical suspicion of hypoadrenalism, she was commenced on hydrocortisone, at which point we were involved. And we wrote in the notes saying that please watch out for high urinary output. And this is for a specific reason, which I will come back to again. So 3 points I have highlighted so far: the sodium, potassium, the urea creatinine pair of abnormalities, and the third point here being to watch out for a high urinary output. And in fact, that's exactly what happened. 5 hours later, the blood pressure was unrecordable. There was a cardiac arrest call put out, but fortunately, she regained the output with intravenous fluids. Looking through the input-output chart, these were her urinary output, which was quite high subsequent to the administration of hydrocortisone. Prior to hydrocortisone, her urinary output was all normal. So within 5 hours, she passed almost like 2,800 ml. Unfortunately, the nurse documented it very nicely, but failed to inform, thinking that this patient, which the typical nurse would be very worried if there is a low urine output, but not such a high urinary output. I will come back to this as to what the interesting physiology which is involved here. So these are her hormone profile, which showed a low T4 and a normal TSH, confirming a central hypothyroidism, LH, FSH being low, prolactin being slightly high, ACTH being low, and the IGF-1 being low. And this is her pituitary MRI scan, which showed a single metastasis in the pituitary stalk. So this is a coronal section. This is the sella, which has got the pituitary gland here. And this is the pituitary stalk. Normally, the pituitary stalk is like a thin thread, but here it is thickened. And what she has got is a metastasis into the pituitary stalk, which has completely wiped out the pituitary hormones. As I was explaining earlier, all the pituitary hormones are under tonic stimulation. Therefore, when there is a blockage here, the stimulation is gone. Therefore, all the hormone levels will come down, except for prolactin, which is under tonic inhibition. Therefore, the prolactin, with the loss of inhibition, the prolactin level goes up, which is what we are seeing here. So in summary, this lady has got a central hypoadrenalism, a panhypopituitarism due to a pituitary stalk metastasis. The learning points are very interesting, which reveals many of the interesting endocrine physiology here. Somebody who has got a history of cancer, when they present with hypoadrenalism, automatically it is easy to think that this patient has got an adrenal metastasis, which they could indeed have, because adrenal metastasis in patients with metastatic cancer is not uncommon. But adrenal metastasis to cause clinical hypoadrenalism is not so common. It is pretty rare. Almost 95% of the adrenal gland has to be wiped out before they develop hypoadrenalism. Therefore, in patients with cancer, when they present with hypoadrenalism, we have to think about a secondary hypoadrenalism as the cause, which is the pituitary hypoadrenalism, as we saw in our patient. Now, this explains the secondary hypoadrenalism is characterized by hypocortisolism, but not hypoaldosteronism. Let me explain this. We all know that the adrenal gland has got two important hormones, the cortisol being one, the aldosterone being the other. One is the glucocorticoid pathway, the other is the mineralocorticoid pathway. When somebody develops an adrenal insufficiency due to an adrenal problem per se, for example, Addison's disease, that's where we typically see both being deficient, both the cortisol and aldosterone being deficient. With the cortisol deficiency, they may have hypoglycemia, hypotension, etc. With the mineralocorticoid being deficient, they will have a hyponatremia and a hyperkalemia. But the aldosterone axis is not under the control of pituitary. It is under the control of the juxtaglomerular apparatus, which is the renin-aldosterone mechanism. Therefore, somebody, when they develop a hypoadrenalism due to pituitary deficiency, it is mainly the cortisol that is affected, like in our patient. And that's why this lady did not have the typical hyponatremia and hyperkalemia. Therefore, it's important to remember that secondary hypoadrenism is characterized mainly by hypocortisolism, not by hypoaldosteronism. Now, the fourth important point, which is also very interesting as to why she developed rapid increased urinary output after giving hydrocortisone, is just this, that for renal free water clearance, cortisol hormone is very important. When there is a coexisting cortisol deficiency, when I say coexisting, somebody who has got a diabetes insipidus, but they also have a cortisol deficiency, then they do not manifest the DI. The DI is completely masked. Their urine output is often normal. The moment we administer and replace the cortisol, the free water clearance increases and the DI is unmasked. So correction of hypocortisolism in this setting may unmask a DI, resulting in rapid onset of polyuria, which is what happened in our patient. It's also important to remember that pituitary adenomas rarely present with diabetes insipidus as a sole presentation. Therefore, if that's the case, we need to think about other infiltrative disorders. The fifth patient is a 76-year-old female who presented with acute breathlessness. She gave a 3-year history of episodic palpitations and sweating, 2-week history of abdominal pain and dyspnea. She had a past medical history of osteoporosis, for which she was on alendronic acid and calcium vitamin D tablets. On examination, she was looking unwell. She was quite agitated. The temperature was 38 degrees, but she had a cold peripheries. The pulse rate was elevated about 120 to 190. Clinically, it was not clear whether that was regular or irregular. The blood pressure was quite elevated at 190 by 110. The JVP was elevated. She had a soft ansystolic murmur at the apex. She had pitting edema to the anterior abdominal wall. There was bilateral crepitations and there was some right-sided abdominal tenderness. So the question is whether this lady has got an SVT, supraventricular tachycardia, and congestive cardiac failure, maybe a chest sepsis, or given the right-sided abdominal tenderness, whether she has got a mesenteric ischemia. These were her initial investigations. Many of these were looking a bit abnormal, but would be consistent if there were to be any sepsis like elevated white cells. Troponin mildly elevated, but this could happen with an SVT. CRP elevated, again, can account for a sepsis. The thyroid functions were normal, she being tachycardic and agitated. This could also account for thyrotoxicosis, but the thyroid functions were very normal. That's her ECG, which confirmed that she indeed had SVT at about rate of 170, and chest X-ray showed an enlarged cardiac shield with features of congestive cardiac failure. The CT scan was done there because of the abdominal pain and tenderness that she had. This showed a large right-sided adrenal tumor. This is the tumor with the central necrosis. So a very heterogeneous appearance of the adrenal tumor. The clinical suspicion of a pheochromocytoma was confirmed with these metanephrines, norepinephrines, adrenaline, everything which were elevated. The MIBG scan confirmed that the uptake in the right adrenal gland was high, confirming that this indeed was a adrenal pheochromocytoma, but no other lesions elsewhere in the body. So this lady has presented with what we call as a pheochromocytoma crisis. Again, pheochromocytomas can present to your OPD, but this lady presenting with features of cardiac failure, SVT, agitation, etc., very much like our patient with thyrotoxic crisis. This lady has also presented with pheochromocytoma crisis. We don't see that often, but having said that, yesterday we had a patient got admitted in the hospital with exactly another episode of pheochromocytoma crisis, completely newly diagnosed. He didn't know about it at all. When he came to the emergency room yesterday, his blood pressure was about 230 over 120. He was quite agitated. He didn't have any other past medical history, and he had a CT scan because of some back discomfort in his flank, which showed a large adrenal tumor. And again, he has presented with the pheochromocytoma crisis. So not the common presentation of pheochromocytoma as such, but it is very important again to pick this up to treat because the mortality is quite high. Adrenaline action, which is in excess during crisis, can even precipitate an acute MI and death. This lady was admitted to the critical care unit. She was commenced on phentolamine infusion. Verapamil for her SVT was given, IV diuretics, and CVP monitoring and crystalloids with IV antibiotics. Subsequent management was, as we know, in pheochromocytoma, we want to block the action of both alpha receptors and the beta receptors, but it's very important that we block in the right sequence, that we block the alpha first before we block the beta. Otherwise, there could be a paradoxical increase in blood pressure. She was transitioned to phenoxybenzamine and bisoprolol and subsequently had a laparoscopic adrenalectomy quite successfully, which relieved her of all the symptoms. The potential triggers in a pheochromocytoma crisis could include metoclopramide. These are less recognized, but these are potential triggers which can precipitate a crisis in a patient who has got pheochromocytoma. So drugs like morphine, fentanyl, tricyclics, even dexamethasone, steroids can precipitate this. Amphetamine and decongestants, phenothiazines, certain radiographic contrast materials, or certain anesthetic agents like atracurium or pancuronium. Any tumoral blood flow changes like a deep abdominal palpation, sexual intercourse, all of these can also precipitate a pheochromocytoma crisis, a surgery or a trauma. And this is again not uncommon that a patient is taken up for some other surgery found to have an extremely high blood pressure once they are on the table because of the stress and subsequently being found to have a pheochromocytoma. So uncontrolled pheochromocytoma or paraganglioma crisis is a potentially life-threatening disorder. The diagnosis should be considered when there is unexplained dysrhythmias, cardiac failure, and other features of catecholamine excess. Alpha blockade must be established before the beta blockade. And as I said, the sequence of drugs are important, and potential triggers, as we saw, should be avoided lest we will precipitate a crisis ourselves. The sixth patient is a 65-year-old male who presented in 2005. He presented to the emergency having been drowsy, inability to open his eyes, difficulty in his eye movement, and the difficulty in his eye movement and inability to open eyes were of quite acute onset. He had a past medical history of obesity, but otherwise nothing else in his history. On examination, cardiovascular and respiratory examination were unremarkable. The CNS examination showed a bilateral third cranial nerve palsy to the extent we had to hold his the eyebrow to see the eyes. His MRI pituitary gland showed, this is the contrast on the right-hand side and the non-contrast on the left-hand side. This showed a large pituitary tumor, which is elevating the optic chiasm. This is the optic chiasm here with a central black area, which is the apoplexy. So this gentleman has had a pituitary adenoma into which he bled, and the sudden bleeding will cause an expansion in the pituitary gland. And we all know that the second nerve is on top of the pituitary, that is the sella. The third, fourth, and sixth cranial nerves are on the sides, which is here, which is the cavernous sinus. So a sudden expansion of a pre-existing pituitary adenoma due to an intratumoral hemorrhage can cause a cranial nerve palsy, and this gentleman is presented with a third cranial nerve palsy. These were his initial investigation, which showed a low T4, LH being low, testosterone low, prolactin low, IGF-1 low. Interestingly, the cortisol hormone was not actually very low. It was nearly normal, which is another important thing we need to remember, because it's very unusual for someone to preserve the cortisol axis and wipe out all the other axes in the pituitary. He underwent an emergency pituitary surgery. Visual symptoms improved back to normal. The immunostaining showed that this was diffusely positive for corticotroph, which is the ACTH, and the final diagnosis at this point was a silent corticotroph adenoma, which is not an uncommon entity, where there is a corticotroph adenoma, but the patient has not manifested the symptoms yet. Therefore, it's important that we follow these people through, because they may manifest the symptoms as we follow them through, which is what happened in our gentleman. For 2 years, he remained in remission, but 2008, he represented that he gained 16 kg in 6 months within a very short time duration. There was a significant deterioration in his exercise tolerance. He had a Cushingoid features with facial plethora and central obesity. These are the typical reddish striae or purplish striae that we see in patients who have got Cushing's disease or Cushing's syndrome. So these are some of the investigations which we do in patients with suspected Cushing's. Essentially, the urinary cortisol level was, this is the 24-hour urine cortisol level that was high. The dexamethasone suppression, where you give exogenous dexamethasone, you would expect the endogenous cortisol to go down, which is not happening. We all know that cortisol has got a circadian rhythm where the maximum cortisol levels are in the morning and it decreases as the day passes by. And one of the earliest features of Cushing's is that they lose the cortisol circadian rhythm, where the cortisol levels are the same across the day. The ACTH was measurable or elevated, confirming that this gentleman has got an ACTH-dependent pituitary tumor or a Cushing syndrome. A repeat MRI showed no tumor or recurrence in the pituitary area itself, but he had a CT scan which showed hypodense lesions in the liver, which were suspicious for metastasis, and the biopsy from the liver showed intense ACTH staining, confirming the diagnosis of a pituitary carcinoma with metastasis to the liver. Pituitary carcinoma is very rare, but when it happens, often these are Cushing's tumors which present with pituitary carcinoma. This gentleman went on to have radiotherapy, chemotherapy in the form of temozolomide, and subsequently he passed away. So the learning points from this case is that pituitary tumors, especially when they are apoplexy, can present with cranial nerve paralysis, like third, fourth, or sixth cranial nerves. Silent corticotroph adenoma is a well-described entity when patients do not have any clinical features of Cushing syndrome, but it is important to follow these people through because they may manifest like what happened in our patient. As I said, pituitary carcinoma itself is very rare. More than 99% of the time, these pituitary tumors are benign in nature, but when it happens, often these are Cushing's tumors. The last case, a 44-year-old female who presented with mood swings, weight gain, which is more in the central area in the abdomen, facial puffiness. She had a past medical history of asthma and colitis, for which she was on beclomethasone inhaler, azathioprine, and Azacol. She had a family history of type 2 diabetes and colitis. On examination, she had a central obesity with a facial plethora, suggestive of Cushing syndrome, and the investigations also confirmed the same. The urinary cortisol was elevated. Dexamethasone suppression showed that it was not suppressed. The T4 level was low, showing some evidence of hypopituitarism. But when she was being prepared for the surgery, 3 weeks down the line, she presented to the emergency department with frank psychotic episode when the evening cortisol was very elevated. This is a different unit. This was a patient whom I saw in the UK, so the units are different here. But the normal being 520, her level was 1,417. Another important biochemical marker I would like to highlight here is the low potassium that she presented with this 2.9. So impression was that she is probably presented in the background that she has already been diagnosed with Cushing syndrome, that she has presented with frank psychosis due to Cushing syndrome. But given her presentation, we were unable to administer any oral medication. She was literally thrashing around in the emergency department. She could not be restrained at all. She was a well-behaved policewoman prior to all these things. So she had to be admitted to the intensive care unit. we had to administer something called the etomidate, which is one of the anesthetic agents, which is not being used now. When it was used in the early days, the etomidate, after being given, they found that the mortality was high perioperatively. Subsequently, it was found out that etomidate can wipe out the adrenal gland, and it can cause adrenal hormone blockade, which is cortisol deficiency. And people died of cortisol deficiency due to hypotension and hypoglycemia. So this was used as an advantage to treat this patient. So we infused her with IV etomidate. She was intubated and ventilated. Subsequent appropriate treatment for Cushing syndrome itself was given. We had a very tough time in treating her, in controlling the Cushing's itself. And this graph, I'm not going to go through the graph in entirety, but just to highlight that when we are administering the etomidate to block the adrenal hormones, it's very much anticipated. She can also become hypoadrenergic, which means she can develop cortisol deficiency, because it's a very potent agent which will block the adrenal hormones pretty quickly. So it's important to replace the cortisol also. Therefore, she was treated with dexamethasone and hydrocortisone as needed. Subsequently, the MRI showed right-sided pituitary adenoma. It's a tiny pituitary adenoma, but we can see what sort of havoc it can cause with the excess cortisol in her body. She had what we call as an inferior petrocell sinus sampling, which essentially the catheter showed that there was too much cortisol coming from the right side. This we do to make sure that what we see as a pituitary tumor is not an incidentally found tumor, and it is indeed the reason for pituitary Cushing's. And that's where this test is important. Anyway, subsequently, she had a transfemoral surgery. She went into remission. So the key points from this is that although patients with Cushing syndrome often present with gradual onset symptoms, sometimes the presentation can be quite acute, like with psychosis, as we see in our patient. And hypokalemia is one of the important markers of an acute presentation of Cushing's. When it is a gradual, insidious onset Cushing's, we don't often come across hypokalemia. Patients with acute Cushing syndrome may not have the typical features like the striae and easy bruising, which we saw in our previous patients. All that they can present with is a sudden weight gain, some sort of edema, and a hypokalemia. This can be the presenting feature of an acute Cushing's. And again, untreated Cushing syndrome has a very high mortality, approximately 50% at the end of 5 years, and it is mainly driven by cardiovascular mortality. So I walked through about 7 patients who I have managed in the past few years, who all presented to the emergency department as an emergency presentation. We have picked up some of the thyroid disorders like the thyroid storm here, acute Cushing's, acute hypoadrenalism, pheochromocytoma crisis, and a pituitary apoplexy. So my presentation was not meant to be actually teaching through each and individual cases, but just to give a flavor as to what sort of things we can expect and see in patients with endocrine disorders presenting as emergency. And it is mainly to make sure that we don't miss, because often unlike other system disorders, let's say somebody who has got an acute chest pain, anybody would immediately think of whether this could be a heart attack. Somebody who presents with an acute breathlessness, anybody would think of whether this could be an asthmatic attack, because these other diseases and disorders are more of organ dependent, whereas the endocrinology is very different. Endocrine based diseases present with symptoms which are very non-specific, and it could involve from head to toe. Because these presentations are not so specific and not so typical, which we see with organ based dysfunctions, these could often be missed both in the chronic setting and acute setting. So I hope this presentation would have given an overview of what sort of endocrine emergencies that we should not miss, not necessarily to treat, but at least to pick it up and highlight it to the endocrinologist so that these can be taken forward. I thank for the wonderful opportunity given to me to present to the august audience here today. And I thank my co-panelists, Dr. Jaishri Gopal and Dr. Muthukumaran Jaipal, who kindly agreed to be here today. Thank you.
Your mic is on.
Thank you so much, sir. It was a really wonderful eye opener to all of us. Dr. Pala Rajesh sir, welcome to the webinar. I will just ask ma'am to join us. She's on the second floor. She'll come now. Sir, actually, you've really thrown us out of gear with so many this thing, because T3, T4 was something very ordinary for all the clinicians, at least people like me. And suddenly to say just the TSH value alone can tell you that there is something wrong with the pituitary was quite alarming and nice. I think we'll take on to the panelists. After the discussions are over, maybe we can throw it open to the floor. Is that all right, sir?
Thank you.
So you can introduce the panelists yourself and they can continue with the seminar, sir.
I think we have the introduction at the beginning. I would like to ask my fellow panelists for their comments and expert opinions.
Yes, sir.
So, shall I go first?
Yeah, sure, Jaishri.
Okay, thanks. I mean, wonderful cases, Narayanan, and really, I think teaching for all of us, not just the physicians, good revision. A couple of points and a couple of questions. One is, I think we all agree that when we are called upon in the intensive care setting to diagnose hypopituitarism, we are given cases of like a sick thyroid, you have a low TSH, low T4, low T3. So one of the things I wanted to mention, which may be of help, is that at least if it's a lady above the age of 50 who has, you can check an FSH, and if it is low, it gives you some idea that this could be a hypopituitarism that you're dealing with. In men, this does not apply, because in men, the LH-FSH levels anyway tend to drop with age. So that was one thing I wanted to mention. And second, I think you had made the strong point that when you give steroids in hypopituitarism, watch out for diabetes insipidus. The other very important factor when we are treating hypopituitarism is always give the steroids first. Do not start thyroid hormone replacement. So if you have somebody with thyroid and with, say, suspected cortisol insufficiency, and you're waiting for some cortisol report, don't start the thyroid tablet alone. Wait for the cortisol report. If necessary, treat that, because again, if you're going to give the thyroid, it will precipitate an adrenal crisis, similar to how here giving the steroids precipitated a DI. That giving the thyroid first would precipitate a adrenal insufficiency. So that's one more thing. Anytime we see anybody with severe recalcitrant hypotension, particularly in an emergency room, think of cortisol, adrenal insufficiency, cortisol deficiency. We have seen in our country a couple of times people presenting with, after having taken whatever be the medicines, they either use like over-the-counter steroids, they use it for skin conditions, they use it for allergies, arthritis, asthma. So quite often they have suppressed access. So anybody who comes in with hypotension of unknown cause, remember to just check a serum cortisol and get them started on steroids. You can send off a random cortisol and get them started on steroids. The question I had, maybe I'll come to that. I'll wait for Muthu to finish his comments. I just had a couple of questions, Narayanan.
Fantastic cases, Narayanan, again. I was just going to point out for the audience per se is with the thyroid to start off with, when we are talking about central hypothyroidism, a lot of the times people do a total T4 and TSH, and you don't need really see an end of the spectrum range when you do a total T4, when you're looking out for central hypothyroidism. So a lot of the times it gets spelt as probably low normal, spurious, leave it off. So if somebody comes across a range which is on the low normal for a free T4 or even for a total T4, my advice would be just to repeat it after a couple of months or even 6 weeks. 3 months would be a longer period of time, so they get missed out. The second thing is with regards to steroids, I was fascinated by your DI precipitation. But the same thing happens even when you start off on a very small dose of steroids as well in our patients with long-standing hypopituitarism. So whatever happens in Cushing's, if we start even hydrocortisone 10 milligram, we've had a couple of patients who went into psychosis because of that. So whenever you're starting on somebody very chronic, acute is a lot different. When you're starting on a patient who have been running low for some time, I've gone into the practice of starting at a lower dose rather than giving them a full dose of hydrocortisone. I start them at a 5 or a 10 and see how they get on over a few days before I put them up to 15 or 10 again. So that's This is particularly in patients who have been uh, on off treatment or without treatment for many years, and then they land up at this thing with chronic hyponatremia and so on. So those are the one thing, fantastic cases I also enjoyed and learned. Thank you.
Thank you both.
So just my two questions were management of the myxedema coma and management of the thyroid crisis. Very quickly, if you can tell us how to do it in our country.
Thyrotoxic crisis, I think we went through as we start with the anti-thyroid medications, carbimazole and propylthyroxine. These have to be the first medications before we administered iodine, which is going to cause the Wolff-Chaikoff effect and block the thyroid hormone production further and the secretion as well. So the order should be a carbimazole or PTU, preferably a PTU because it blocks the conversion of T4 to T3. And then you add the iodine. The adjunct treatment could be dexamethasone, again, which has got an action in preventing T4 to T3 conversion. All the other treatment could be adjuncts to the oxygen, IV fluids, correcting the other measures like antibiotics to treat the infection, etc. Myxedema coma, fortunately, we are not seeing nowadays at all, or very rarely we see that nowadays. We can see patients with gross hypothyroidism, but because the TSH and T4 tests are being done so often and so frequently, it's almost become part and parcel of many of the even master health checkup packages. So unlike yesteryears, we don't see this so often. Just in case if we do encounter myxedema coma in our country, it's possibly slightly difficult. The reason being to obtain, for example, an IV liothyronine, which is often the first standard treatment that we can use in myxedema coma patients. We don't get the liothyronine here in our country. So liothyronine, as we know, is the T3, which is not the T4, which we standard use with levothyroxine. T3 is the most biologically active form. So somebody who's got a myxedema coma, you want to administer directly the T3, and liothyronine in other parts of the world are available as an intravenous infusion. You can start off with 10 micrograms twice a day and then build up the dose to thrice a day if necessary. Once a patient is a bit more responsive, and again, you start off with both liothyronine and thyroxine, so that by the time the liothyronine has kicked in and started improving the patient, the thyroxine is also in the system to improve, because the thyroxine is not going to act immediately. The rest of the measures are going to be symptomatic management. And in patients who have got frank myxedema, let's say with hypothermia, their metabolism is going to be much slowed down. Be it the heart rate when they're present with bradycardia. So generally warming up, keeping them with the away from the metabolic dysfunctions, the outcomes could be really good, and we can save them out of this very easily. The IV thyroxine, which is sometimes available in our country, again, not easy to get. I've used only in 1 or 2 occasions in India, where one of the patients was a patient who had a previous head and neck irradiation. He had a stenosis of his esophagus and laryngoesophageal stenosis, and he was going to this was a day when he was about to go and have a surgery done, an ONCS procedure, where they were going to do a laryngoesophagectomy and going to have a gastric pull-up procedure for this, because he had a complete obstruction of the esophagus where he could not even swallow totally. On the day of surgery, they had the TSH-T4 done, which showed that he was grossly hypothyroid. And there, I could not even administer the thyroxine tablet. He couldn't swallow anything. So I had to use IV thyroxine, which is immensely costly. 100 micrograms of a tablet cost 1 rupee. 100 microgram IV thyroxine costs, well, on that day, it was 17,000 rupees. But we had to use it for a few days. And to my surprise, because we know that myxedema and severe hypothyroidism can cause peripheral edema, which is visible. We see this. They have leg edema. This was a very important learning point for me by managing that patient. I did not expect this to happen, but in retrospect, what happened was he had a lot of edema over here at the site of the esophagus. So once we started administering thyroxine, the edema started resolving. He was able to take fluids on the 3rd day, and he was able to take the tablets from the 4th or 5th day onwards. So till date, he's not had a surgery yet. So only a couple of occasions where I had to use IV thyroxine. Liothyronine, we are not able to get.
Thanks, Narayan. That's all I have.
So can we ask Dr. Pala Rajesh sir, do you have any inputs from your side?
you very much. I arrived slightly lately, but this was fascinating. It was an amazing walk through endocrine emergencies, Dr. Narayanan. I am a cardiothoracic surgeon, the vice president of the Royal College of Surgeons of Edinburgh. And I think that at some stage, I'd like to invite you to speak in one of the webinars that we conduct from the College of Surgeons. It's been a real learning experience for me. The only involvement, as far as I'm concerned, as a cardiothoracic surgeon, is through video-assisted thoracic surgery when I help the ENT surgeons with very large intrathoracic goiters and also to locate parathyroid adenomas and to take them out through a minimal access technique. And very, very rarely, when we see oligometastatic disease in the adrenals, secondary to lung cancer, when we screen them post lung cancer, 6 months to a year after the initial surgery, when we do get people with metastases, and if it's oligometastatic, either in the cranium or in the adrenal, we get involved in removing these tumors. But apart from that, it's been a fascinating run through your experience, which has been fascinating. And thank you very much for sharing that experience with me.
Thank you, sir, for the comments. Interesting that you mentioned about the VAX procedure, which reminds me of another patient, which myself and Dr. Jaishri was discussing only today. I had a patient who's elderly, 70-year-old. She's a VIP from Chennai, who presented with the acute onset of leg edema and excessive weight gain within 2 months time period. And to cut the long story short, she had an acute Cushing's presentation. And when I was searching for the tumor, she had a small tumor within, just underneath the cardiothoracic cavity, just underneath the chest rib cage. And eventually she had, this is a case of an ectopic ACTH secreting Cushing's syndrome, Cushing's tumor. And eventually she had a VATS procedure done by one of our cardiothoracic surgeons. Within few weeks, she started getting much better.
Great, sir. Sir, if anyone else has any questions or comments? Sir, Narayanan sir, it was just enlightening, as I told you. Forgetting the emergencies, how often do a clinician refer to an endocrinologist if there is a disparity between T3, T4 value and the TSH value, sir? Because lab to lab also there is a small difference. So how often do we go and just tell the patient, please go to an endocrinologist and don't continue with us?
Very valid question, madam, especially in a country like us where the standardization is of a very big question. There are different types of assays that are available for any hormones. Yes. Unlike for other tests, like for example, the CBC, which can be run by any automated machine. You just need to buy a machine and just install it. It will automatically give the reports. Whereas when it comes to radio immunoassays, especially with the hormones, there is quite a lot of variations that we can come across. So my impression and my advice to the physicians always has been that if the reports in front of us do not match with what the patient is presenting to you, repeat, or if you can't, then at least refer. This applies to many conditions, the TSH, T4 being the most common ones. As I was explaining earlier, there are other conditions which can also present with an atypical presentation, where the T4, T3 is low, but the TSH is not elevated, or the T4, T3 is elevated where the TSH is normal. These could account for situations like an assay interference with either of the assays, the TSH assay or the T4, T3 assays, or it could be a rare presentations like what we saw with the TSH secreting adenomas. So standardization of lab is one thing, and for at least the endocrinologist, I think it's very important. I'm sure my colleagues here would have a vast experience with this, that it's important for us to know what type of assay the lab is performing, because in a given particular specific condition that we are suspecting, even amongst the thyroid disorders, for example, if there is a question regarding, let's say a TSHoma, or let's say another rare condition called FDH, familial dysalbuminic hyperthyroxanemia. So depending on what we are suspecting, the assay that we have to use is also going to be different. Some of the assays will be performing better in a specific situation like FDH. Some of the assays are more preferable in a specific situation where it would give a more accurate results. Dr. Muthukumaran also has got quite a vast experience in this area. Got something to add?
I think I've got a dubious distinction of running a lab for the last 10 years. That's all it is. But that gives me a lot of experience as well. So I would totally agree with you that if things don't correlate very well or not going in with your clinical opinion, or if you feel it is odd, then definitely you need to talk to your lab or your biochemist or your endocrinologist, whichever you're comfortable with. So that's where a lot of the times we see central hypothyroid patients or even our TSHOMA patients being dragged for 3 to 4 years without getting the needed help. So most of the times, if you see them, they're being basically fluttered off saying it is a spurious result. This patient always has this report. So if at all, if anything is not making sense, just talk to a person who would be able to help you, like your biochemist or an endocrinologist would be a first choice.
Yes,
Yeah,
sir.
I think the biochemist just, yeah, sorry, ma'am.
I have one more question, not related to any of this. It is more for diabetes. There are patients who come with low fasting and a high PP. Does that anyway signify something? Because those are the patients whom we see quite often, sir. And we get perplexed as to are they a diabetic person or not? Any comment on that, sir?
Dr. Jaishri, would you like to?
I mean, both ways we do see it. I think the more perplexing one is where the fasting is elevated, but the postprandial is low. Quite often, people get concerned about that. How is it that my fasting is like 110 or 120, but my postprandial is 80? So that does tend to happen sometimes, and that's due to various reasons. But the reverse is also true, where your fasting could be 80 or 90 and your postprandial could be high. It could be 200. That predominantly just reflects the sort of high carbohydrate meals that we have. So that is
So I think we have lost her for a second.
She's back.
Yep.
Yes, ma'am.
So just to add to what Dr. Jaishri was also explaining, we have even had situations where patients came and complained saying that always it has to be the fasting that is low and the postprandial which is high. How come it is reversed? Your lab is wrong. The reports are wrong. The patient has complained saying that the fasting is more than my postprandial. It can't be right. Your lab is wrong. So we have to understand the epidemiological studies have also shown that almost 20% of the individuals can have this pattern where the fasting could be elevated and the postprandial could be low. Again, as Dr. Jaishri was alluding to, it really depends on the metabolic profile of the patient or the person and the sort of pattern of eating that we have. Somebody who is always used to have a late night eating habits, obviously the fasting is going to be on the higher side. The hepatic glucose output in a pre-diabetic individual is also going to be on the higher side. Therefore, these patterns are not uncommon when we do lab investigations.
Thank you, sir. Sir, any more questions from the floor? If there are none, then I take the pleasure of thanking Dr. Narayanan and
necessary. And when you look at the diagnosis,
sorry.
So Dr. Jaishri is back.
Yeah. Okay. Yes, ma'am.
no, I think Narayanan answered my.
Yes. Yes, ma'am. Yeah, so I shall have the pleasure of thanking all the three of you and Dr. Rajesh also, and thank all the other participants who have participated in the webinar. Our next webinar will be on the 21st of this month, and the speaker is Dr. S. Natarajan. He's an ophthalmologist. He's an honorary emeritus professor from our university. The timings will be the same. We'll put up everything else in the webinar series. Thank you so much. Thanks a lot, sir.
Thank you very much.
Thank you. Thank you.
Thank you.